Hello, everyone. Welcome to EULAR 2026. We're all here in London and have had a busy day one and day two. This program is our daily recap of highlights from the meeting as seen through the eyes of the four of us, the faculty who've been scouring the meeting for the interesting oral presentations and abstracts. The meeting started yesterday in the afternoon, another busy day today. So today's recap is a day one or day two, and the faculty get to choose what they want to present. We're going to do our first round and then a shorter second round. So we'll cover at least 8 abstracts in this. I'm going to begin by asking our faculty to introduce themselves. I'm Jack Cush from Dallas, Texas. Bella?
Hi, I'm Bella Mehta from New York, here in London, looking at abstracts for EULAR.
Very good. Aurelie?
Hi guys, this is Aurelie Najm from Scotland, and I'm live from London as well.
I'm live
Dr.
from
Pope?
London. Yeah. Hi, Janet Pope. I'm from the other London in Ontario, Canada, but it is on the Thames.
That's
But
a
I'm
cool
here, but
little
I'm here in the real one.
that's a cool little twist. She just only lectures in London, only teaches in London. And she's got a few of them to choose from. Okay, so let's begin with Orly. What's your one of your favorites from the first 2 days?
Yeah, so on the first day, I went to this RA session, and there was a lot of therapy. How do we treat? How do we manage new drugs and so on? But there was one abstract that caught my attention. OP0204, actually, it was today, not yesterday. Anyways, it's the back study, and when we talk about shared decision making in RA, it's always qualitative study or surveys, and it's never really randomized or high level of evidence. So this is why, and I noticed this one, and I wanted to report on it. It was a randomized control trial where they were looking at two groups of people living with rheumatoid. One group of 50 people that were just assigned the first biologic based on standard of care, the physician chooses. Or they were watching a 3-minute video. So it's not a super long therapeutic education session. It's a 3-minute video that they watch, and they get leaflets on the drug, and then they get to choose. Do they want a JAK, in which case it was filgotinib, or do they want a subcut TNF inhibitor? And what's really interesting as well is that the way people choose, first of all, everyone was able to make a decision within 48 hours. Um, Second of all, the way they choose was basically half and half. There was like 28 wanting the Jack and 23 wanting the TNF. So it's not like everyone wanted the oral drug. Um, and what came out of this was that obviously, if people get to choose their drug, they're actually more happy. Not only they're more satisfied, but also they experience less adverse events. They're more likely to stay on the drug over time. So the retention is much better, and they're less likely to switch drug. Why is that interesting? I think it is interesting because obviously it doesn't mean it works better, but what it means is that people are less likely to want to discontinue it if it's working, which I think is important. Obviously, there's one caveat in this study, which is they started recruiting before the oral surveillance results. So at the time when they started, obviously it was anyone could choose anything. But then as the warnings appeared, then they had to obviously be much more careful with who they were suggesting filgotinib to. But in any case, I think it is interesting because um, I don't think I often tell people, okay, you have all these options. Which one would you like? We cannot direct them, obviously, based on comorbidities and all, but I'm curious how I could inform my practice with this, just a bit.
I used to get accused in the clinic of tricking my patients or trying to trick them because I would give them 3 choices. And then they would say, "Well, Dr. Cush, why are you giving me 3 choices? Because you yell at me if I don't choose number one." And it's sort of like, that's not really what the intention was. But I love this idea because when you do clinical trials, people get randomized to A arm, B arm. Why not a C arm where patients get to choose? Because when they choose the story in their head is so much better, and the buy-in and the retention and adverse. I thought that was so cool. I think that this really should inform how we do clinical trials, but really, like you said, what are you going to do in practice? So how do you make that? So how could you do this in practice? Do you have to make video packages that you say, I'm going to send it to you and watch it at home after they talk to you? That's one way.
I mean, we all give handouts. Sorry, yeah.
No,
Yeah.
go ahead.
No, we all give something like handouts to read up, but I don't know. I think videos are maybe a better way of communication sometimes.
Yeah.
I was just going to say I have a bit of a different take on it because I thought the people willing to be randomized would be more likely to stay on something because they had a willingness to say, we don't know what's going to be better or we don't know what to choose, so I'll just try it out. So I thought they'd be more open-minded and would stay on drug, and finding that they're more apt to come off drug. I mean, trying to do clinical trials, it informs me a little bit that a parallel group might be important to look at what happens in the real world of those eligible who don't really get randomized. So I was actually a little bit surprised that it was very different, and it was. But I think we have to remember, if we're going to give handouts or inform patients, you can't give too many choices. Like Jack, as you were saying, two choices, maybe a third one that they won't choose anyway, but too many choices, people get overwhelmed as well. So I thought it was actually a neat little study.
Maybe the answer, Dr. Kavanaugh from Galway played with a tool that he liked for a while that was where you could send a patient a recording after the visit, and it would summarize what we did today. And, it was a nice way of doing a follow-up, but we don't have to do that in this era. AI can do this if you have ambient dictation and whatnot, and it's covering this. It can send a package of either audio and maybe even a video that could let patients make decisions afterwards. But yeah, I mean, this is probably the best example of shared decision making, is it not? Cool paper. Bella, what do you have?
So I wanted to talk about the plenary on obesity and RMDs and the potential of GLP-1 agonist. So this was a plenary today talking about a lot of things, but why GLP-1s are important to rheumatologists. I think, there's data that they are present on leukocytes, which sort of change the pro-inflammatory cascade to the anti-inflammatory cascade in terms of the cytokine profile. They're also present in the synovial fibroblasts. So these receptors are present, which makes sense that a lot of my patients who are on GLP-1s for many different reasons sometimes respond, some of their disease activity measures get better. And there's a abstract sort of going on with this is, or a recent study published talking about izekimumab for psoriatic arthritis along with terziparatide. So again, these are studies that are going to be coming in more and more, and you'll see that patients, especially metabolic syndrome plus some of the rheumatic diseases, we'll see much more uptake of these medications. And there's like so many indications that they're trying, especially osteoarthritis, things that we're going to be treating. I have, again, there's a lot of patients that are on this. 6% of the US population apparently has been exposed to this. I think the one thing that everybody always talks about with GLP-1s is muscle loss, and make sure you do add exercise and resistant training and all that. The second thing that people are not talking as much about, I feel, is osteoporosis. And there was an abstract OP0177 talking about osteoporosis. It was like a huge data set, Trinetics. But more importantly, looking at adults who are on GLP-1 and bisphosphonates, and did a propensity match control with GLP-1 patients who are on bisphosphonate and not GLP-1, and they were looking at sort of adverse effects of bisphosphonates, hypocalcemia, femoral fractures, atypical femoral fractures, etc. And seems like they were not different. Again, it's a 5-year study looking at this, but more importantly, the fact that we don't know the actual incidence of osteoporosis on this drug. It needs to be highlighted and looked at because, losing a dramatic amount of weight may cause that, and we need to be mindful with our patients. Yeah, I think it's an interesting drugs. I mean, a set of drugs like GLP plus GIP. That's the second generation. There's third generation, fourth generations coming in. And again, we as rheumatologists are not using these medications right now as much, but I think in the next few years we'll be sort of starting to combine some of them with as treatment strategies for our patients. So it's important to get to know them.
Janet, what do you think?
So I have probably two comments. So I never even thought about the OP. I mean, when we have patients, say, hospitalized that lose a lot of weight by starvation, they lose a lot of bone mass when they're lying around in bed. So I guess if someone's on a GLP-1 losing weight, but exercising and eating healthy, who knows? One thing. And then I think you're right about the indications. They'll go on and on. And of course, recently published in New England Journal was their the Lilly IL-17 drug with the combo GLP-1 plus GIP, or the Lilly drug alone, so the ixekizumab. And it showed that it was better it was active PSA patients, that it was better in the active PSA being on the weight loss drug. I think the big question, though, is if you are normal weight and a non-diabetic or slightly overweight but not meeting obesity criteria, will you also get bang for your buck on these drugs, as I'll call them, more anti-inflammatory than weight loss, losing some of the visceral fat or whatever other fat around our organs that is probably pro-inflammatory? And I don't think we know that yet.
I
Yeah,
think
there's
there's
experience.
studies on the way.
Yeah, go ahead, Bella.
No, there are studies on the way, and the fact that these receptors are present in synovium, things that we care about. And there's some early data on how these drugs may change some of the inflammatory cytokine profiles even before significant weight loss happens, right? Again, these studies need to happen and will happen, but even with data on retrospective stuff, patients are on it for various reasons, and you can look up their outcomes. Jack.
Yeah, the cardiovascular benefits are there, and even in the cardiac patients and in sleep apnea patients where there are indications here. And when the weight loss isn't all that great, the other interesting thing is that in people that don't have diabetes, their blood sugars don't change substantially. They get, they go down a little bit, but hypoglycemia is quite uncommon with this. But the muscle mass is a gigantic issue, I think. And then there's all these weird things about blindness and whatever. There's going to be these small fringe serious adverse events that everyone's going to have to be expert at, because even if you're not using them in the treatment of your rheumatic disease patient, everybody else is using them, and it's going to be on board. And there doesn't seem to be, there doesn't seem to be any musculoskeletal or rheumatic adverse event associated with this, although I've read that increases the risk of RA in some people. I think that's a little goofy, but we'll see if that ever pans out. So, but yeah, we need to talk more about this stuff because it's going to be in the literature. It's going to be all over the place, and there's a lot of it here at this meeting. So, Janet, what did you like from today or yesterday?
So, right. So this one's from today. So the same session Orly was in. This is a head-to-head trial. So I picked it. I like it because we're always asking for head-to-heads, and then we seem to not act on the data. So this was an investigator-initiated trial from one country, and it was in active rheumatoid arthritis. They were TNF inadequate responders, and they were randomized to IL-6 inhibition, so tocilizumab, or abatacept. And the primary outcome was a change in CDAI, so the Clinical Disease Activity Index, at week 26. So the first question is, was it supposed to be a non-inferiority, like that they be about equal, or was it supposed to be a superiority? And to be quite honest, I'm not sure, but I kind of got a sense that they wondered if one would be superior to the other, but I'm not really sure what was said that way. So the first
a priori, they said a priori that their experience before suggested tocilizumab might be better. So
correct.
it
So
was
that's right. But they didn't really explain stats, but that's what I wondered too. So number one, change in CDI at 26 weeks was equal. So the graphs were fairly close. There was a little bit more reduction in CDI on tocilizumab, but it was basically equal. It was non-inferior. Number two other important points, because then you can interpret the trial however you want. So they said if the patient was on monotherapy, tocilizumab was better than abatacept, and that was a portion of the patients, maybe about a third, and that's no surprise to any of us. And then he didn't say, because it wasn't really part of the study, but another question was, what about the retention? So he also said retention was better on tocilizumab. So it was an intent to treat. So if you went off the drug you were randomized to, once randomized, always analyzed, and that's what you're supposed to do. So if you believe they're equal by the CDI change at 26 weeks. If you have a belief system that one is better than the other, then you could say tocilizumab had better retention and was better in monotherapy. So I think it's yet another head-to-head where I don't know the take-home message, and whatever I believe before, I'll continue to believe. However, good for them for doing it and to have an investigator-initiated study to ask a question post-TNF that they found was valuable.
You know, the thing about this is that EULAR guidelines, which I really think are great on RA, have said, you know, you're one and done. When you use a class, you should move on to another class, as opposed to, you know, primary non-responder, secondary responder, you know, changing your TNF inhibitors and staying just, no, that you should move on. And it's data like this that proves the point. So these people had to fail a TNF inhibitor, 95%. They let some in at the end, but 95% failed a TNF inhibitor. And this showed that it worked. So if you look at the graphs, it looked like they were the same, but does that mean it worked? And they had a mean or median CDI score of 24 going in, and they all
quite high
dropped.
disease activity.
Yeah, they were on the upper
Right.
end of moderate, and they were and had other indications of severe disease, but the magnitude of change was 10 CDI points or more, and
Yeah, it
so
was
it
good.
was. And the fact was that they're both good then alternatives for people failing a TNF inhibitor.
Right.
And maybe Janet's point about the monotherapy is what guides you.
Right. And I think the bottom line too is we can put it in the context that the AbbVie group had recently looked at TNF to TNF, RCT and our active RA, or TNF to upadacitinib. And the idea was, is TNF cycling okay or not? Because people say they don't do it, but lots of people still TNF cycle in RA for various reasons. And what they found in that case is going other MOA that you had mentioned, Jack, going to another MOA was superior. So I think,
Yeah.
you know, we start gathering up these head to head and what to do next. But I think habit is strong and we end up doing what we believe or what we get easier access to, etc.
Okay, so my first one I'm going to talk about was another plenary from yesterday. It's the COMPARE trial, OP008. This was CAR T-cell therapy in refractory seropositive rheumatoid arthritis patients. It's an open label, uncontrolled, 6-patient study. Now, the form of CD19 CAR T-cell therapy is under investigation. They have another cohort that's currently being studied. These people were refractory and they had very active disease. They had DAS28 scores ranging from, I think it was 4.7 to 7.1. Most of them were really quite high. They failed really about 5, 6, 7 prior biologic or targeted synthetic drugs, and they were all on a DMARD, and the DMARD was stopped. They underwent lymphocyte depletion with cyclophosphamide and fludarabine, and then they were given one injection of this CAR T cell, and I just out of respect, I should say the name of it. It's mivocapagene autoleucal, shortened to MIV-cal, MivCal, and then observed. And they all dropped their B cells. You know, all of them got neutropenic. They all dropped their CCP and RF antibodies significantly. But when you look at the on one hand, the presenter said that they all achieved DAS remission, but it really wasn't quite that simple, meaning that they all didn't like just drop like we saw in Georg Schett's lupus trials. All parameters went to zero and stayed down for a long time. That was magical. Here at the end of we by week 12, the ACR 20 responses were 50%. ACR 50 was 33%. If you wanted to look at the maximal responses, you had to go out to 12 months when you're already having B cells and others coming back. So I thought this was revolutionary because people keep talking about CAR T cell as being the great savior in rheumatology, and I'm cautioning, saying you only have uncontrolled data in the worst possible cases. It's not a real scenario for most of us and our patients. But we have to go through the step of drug development, phase 1, phase 2, and train wreck patients, showing safety as the primary outcome. And the good news is safety data on CAR T cell and rheumatic disease has been good. But it looks great in lupus. It looks really promising in systemic sclerosis. And the question is, where does it stand in RA? I've heard rumblings and rumor. This is the first good data, and I'd say it's encouraging, but we need more studies. Aurelie, did you see this?
Yeah, no, I saw that. I think I fully agree with you. I think it also made me think about this other abstract where I think it was OP204, where they used this the T-cell engager as well. I'd have to look back to the name of the molecule, but it's like it looks like there's a whole bunch of data we get from SLE and from Sjogren and from systemic sclerosis where we think, oh my God, this is amazing. And then we translate that into RA. But we need to keep in mind the safety as well as it's not the same disease. So I'm not sure if I would put it anywhere in the management strategy of RA at all right now.
Yeah. Bella?
I mean, it's about what risk will you take, right? Like for an RA patient versus a lupus patient whose kidneys are going off, like how much risk you want to take and what target do you have, right? Like this whole CAR T, I mean, sometimes it feels like, every other disease is going to be targeted with this, but we don't even know which exact cell is causing it. There's subtypes of all these, and for the right subtype, there might be a right CAR. But if the subtype is all muddy, doing a B cell CAR for a T cell predominant patient, I don't know what's the right strategy for those.
So when you use CAR T in RA or BiTEs and T cell engagers, and you don't get the same kind of thing you see in lupus, what is that telling you about the biology of RA? That it may not be as heavily B cell dependent. It may be, more this orchestrated derangement of T and B cells together, leading to the cytokine, story that we and target that we usually make. Janet, what do you think?
Yeah, I think it also leads to the fact that would synovial biopsies have helped to say if you're B cell predominant, because it's not quite what I'm about to say, but about a third of patients look like organized B cells with active RA who have a synovial biopsy, who have been somewhat treated, but ineffectively fully treated. And about 25% are fibrotic. And there's people in between that look B cell, but it's not as organized as a B cell kind of lymph node look. So I think the fibrotic folks, maybe this wouldn't work anyway, but I'm hazarding a guess. So I think like interesting data, not ready for prime time. We need more N and we need longer follow-up, and then we'll make a decision. If you were polyrefractory on pretty much everything, would you go for it with RA? Well, sure. If you're young enough that you've already got damage and you haven't turned off your disease in years, and you're adherent to what's out there, I think you'd probably be consenting to it, saying, well, I want to spare my joints for the next 25 years if somebody's like 45 years old or something. But I don't know yet. No opinion yet.
Yeah, I want to remind us that we discussed in the past, Dr. Pizzales' R4RA study that shows that, and others have shown that the big bad 800-pound gorilla in the in the synovium is the fibroblasts and interstitial the cells that are tremendously damaging, and we're not attacking it. And maybe that's why we see incomplete responses when we target specifically CD19 B cells with this. All right, our final round. I want this to be faster. A minute each on your presentation. We'll start with Bella.
Okay, so this is OP0244. This is looking at pregnancy and autoinflammatory diseases. There's a lot of talk of pregnancies and lupus, etc., but this is good data for autoinflammatory diseases. They included 43% FMF, 37% Still's disease, and other periodic fevers. Total of 51 patients, and 93% patients had live births. So that's important to educate our patients. Only 10% preterm births, again, very, very important. And no preeclampsia or HELP or all the vascular complications that are usually seen with lupus, etc. So autoinflammatory patients, again, these are small groups, much more rare diseases, but important to counsel because a lot of our patients are young.
Right. And so I was going to ask you that question, Bellis, as you follow this literature, there often are reports about pregnancy causing stills, pregnancy causing autoinflammatory disease. What do you think about that?
I think it's the same, like, some things the immune system is triggered, and here it's the innate immune system during pregnancy, but I don't think it causes these diseases. You're predisposed. I think I give that answer to most people.
Very good. All right, Orly, what do you have?
Yeah, I wanted to talk about the first abstract presented at the plenary yesterday, OP001. It's an RCT on gout. We don't have that many of them, so I thought it was interesting. And also, I mean, I think the result was expected, but I think it's a great thing that someone did it. And so what they did is they literally looked at people with gout, treated with urate lowering therapy, follow them up for 24 months, and do we continue or do we de-escalate? So do we taper down the urolithium therapy? So the rule of thumb is we never stop. And I think really it confirms that we shouldn't stop. So yeah, there was 300 people in the study, and all of those who had de-escalation, most of them weren't in remission on the last 6 months of the 2 years follow-up period. Three times more flares, more consumption of colchicine, NSAIDs, and so on. However, one thing that I found quite interesting within all of that is that there still was a subgroup that seems to not be flaring at all. So can we identify these people? I think we need further research, because there might be a contingent of patients in whom we could reduce, but we don't know who they are yet.
Yeah, well, we definitely need more gout research, and I think that the good news is we have drugs coming down in development that will spurn not just the research but also discussion and better education. Okay, Janet, what do you have?
So a really quick one. So it came in New England Journal at the same time a couple of days ago. So yesterday was OP018. So it's the largest RCT in IgG4 active disease. So 194 patients, and they were randomized to, I hope I'll say it right, to obeaxilib. I'm sure I'm probably not saying it right. I apologize. And or placebo. They were on glucocorticoids and then were forced to taper to see if they flare or not. So let's be honest, they weren't on background immune suppression, so they might have been exposed in past to things like rituximab. They were all on glucocorticoids with active disease. So they looked at primary outcome time to flare, and there was like almost a 60% reduction. So hazard ratio 0.44 if you're on active treatment. The rate of flares were approximately double on the people on as they tapered prednisone on placebo versus active. They had 1/3 less cumulative steroid dose, about 300 milligrams in that first year versus about 900 milligrams, and less serious adverse events. So how is this drug different from the other kid on the block, the inabulizumab, which I'm also probably not saying right. It's because they're both affecting B cells, but the new one, the Oboxy, is basically a non-depleter, whereas the other one is a depleter. So the big take home here is we have two drugs now, but none of them, in fairness, have been compared to regular immune suppressives. That are used post steroids in many people, and they haven't been compared to rituximab, which I think a lot of people that treat IgG4 get access to rituximab one way or another. So at least we'll have, I suspect, quite soon now a second drug that we'll be able to consider utilizing. How will we choose between the one and the other? I don't know. Whatever we get access to, I guess. Yeah.
So here's the upside downside. Upside is more drugs for a hard to treat disease is a great thing. More education, more options, more whatever. But more drugs for a rare disease is maddening. Like, how many drugs are we going to need for IgG4 to manage? I mean, we're using rituximab before the current approval, and now this looks really good. And there are other trials that are in play.
Right,
Is this a good thing?
JAKs are in trials, and other B cell depleters or B cell modulators are also in trials. So you're right, we're going to have a rare disease with a plethora of drugs. However, I think what it does is it does, as you say, Jack, bring the research in and the education, because there's probably people misdiagnosed, over and underdiagnosis, I suspect.
All right, so mine, I've changed my mind 4 times during this recording as to what my second one was going to be, and I'm really going to go a little off the path here. Mine's a poster from today, POS 0788 from UMesh and colleagues in India. This is a report on the efficacy of colchicine withdrawal in patients with palindromic rheumatism. You know, it seems kind of oddly boring, but the fact is, this is a real important decision. And so they have a retrospective experience with their number was 765 patients that when they did all their exclusions and whatnot, they had 114 patients who were in remission on colchicine with or without hydroxychloroquine, that being a minority. And then they followed them up, and the idea was that when they stopped the colchicine, that out of the 114, 64 remained in remission, and that 50 relapsed. And so that does add up to 114. One of the ones that relapsed, they reintroduced colchicine, and 36 regained control. So that's about 2/3, whereas 11 continue to be not well controlled. So I thought it was interesting. I thought it's got real practicality to what we need to do in folks. If you make the decision and someone has enough, I think it's a PR. First off, I think is another version of clinically suspect arthralgia, at-risk RA, et cetera. But it's really kind of managed like gout, is it not? If they have, more than one attack a year, you're talking about suppression. If they're having 3 attacks or more, you're definitely all over them about putting them on something. And then what are you going to use? And colchicine certainly needs to be considered because it's cheap. It used to be cheap. In Canada, it's cheap. In the United States, they went crazy. In the rest of the world, it's cheap. But which is why I get all my colchicine from Canada. But still, I think it's a very safe drug and is effective. So I'd like to know what the panel thinks about this.
I
I
mean,
can
I think,
start. Sorry,
yeah.
Orly, go.
Go ahead, Janet. No, go ahead.
Or Bella. Okay. I was just going to say, we just had Professor McGonigal come and talk about, I never thought of it as a stills type picture of the innate pathway going on, because honestly, until he just gave a talk to our group about a week ago, I was not using colchicine in palindromic rheumatism. So after hydroxychloroquine, I would just go to methotrexate if they had too many attacks and I thought they were adherent. And there is that abatacept RCT of preventing more flares, but I can't get access to abatacept after hydroxychloroquine. So I kind of like the whole idea. So that's where I'll stand, is I don't have much experience in palindromic, but it kind of makes sense to me.
I think
Oh,
people add colchicine for different reasons, even for like PMR, maybe like trying to figure out what inflammatory process there is. One abstract that I saw today was colchicine mega doses used by inflammatory arthritis patients for suicide risk, right? Like for suicide. So that's something to be careful about. I didn't even know that's a thing, but apparently this was like an app poster. I don't have the number right by me, but so if you are using it, I would just put a caution there, said you should not be given like mega doses, like they shouldn't have like 6 months supply or something. So that's there was like 21 patients with FMF, young people, mean age 28, and there was like it's a mode of suicide. I didn't know that, so that's something I
that's
learned
crazy.
today.
That's
Yeah.
crazy. That's bad off label, and God help you if you're doing that because there are a lot of deaths with colchicine when it's used improperly, and that's a good example of that. But that scares me to no end. Anyway, final word, or Orly.
Yeah, no, I think it's it's one of these drugs where the toxicity dose is actually quite close to the therapeutic dose, and I think that's the issue. So yeah, always be careful. But I'm definitely open to using it in palindromic, for sure.
All right, I want to thank the panel for a great review of the first 2 days. Encourage all of you to tune in tomorrow for our day 3 recap from EULAR. We'll have a whole new cast of characters. Take care, everyone.